is my abdominal assessment video. My name is Alexis Durham. So first you're going to start by doing a general survey, asking them basic assessment questions based on some of the more common things that people experience in the GI system. First you're going to ask about any recent weight loss or weight gain, if they've gained or lost any weight without trying. Ask about any food allergies that they might have and associated symptoms with that. If they have any dietary restrictions due to religious beliefs or cultural practices. Next, you're going to ask about their hydration status. And you can see that too about a person by, checking their skin turgor. That comes a little later, but asking them how many glasses of water per day they drink, and asking them if they drink water or what they drink. Some people don't drink water. Next, you can ask about their family history, as far as cancer, GERD, any absorption diseases, Crohn's, diabetes, thyroid issues. For African Americans, sickle cell is a big one for abdominal pain and not being hydrated. Next, you're going to ask if it's an older person, if they ever received any blood transfusions, and if they did, when was it? You're basically looking to assess for risk factors for hepatitis. Before the mid-80s, there was no testing for hepatitis B in blood transfusions. You're going to ask them about any previous hospitalizations they've had regarding their gastrointestinal system, any diagnostics they've had, whether it was occult blood testing or CT, MRI, ultrasound, anything like that. You're going to ask them about their appetite, whether it's gotten better or worse recently, if they've noticed themselves eating more or less. Asking about any history of eating disorder or mechanical issues with eating, as far as like pain and in the jaw, or dental pain can cause people to not be able to eat. As far as for the GU system, you can ask them if they've had any past or present UTIs or STIs, menstrual irregularities, any burning, frequency, urgency on urination, any changes in their menstrual cycle. Next, you're going to want to ask them about their bowel habits, their regularity, the type and quantity of their bowel movements, and if there's been any recent changes in that. As far as lifestyle, you can ask them about their drinking habits, the amount they drink and how often, and if they engage in any drug use, recreational drug use. You're going to want to ask them about their over-the-counter medications and their prescription medications. Just for example, taking too many antacids can cause infection in the stomach, overgrowth of bacteria. And then ask them about any recent travel, if they've been out of the country to any third world countries eating food there. What you're looking for there is any risk factors for hepatitis A. And then you're going to move on to the cultural and age-related assessments. For the cultural assessment, the nurse should be aware that people from certain areas of the world or who carry certain genetic markers are going to be more prone to different GI disorders. For example, we should be aware that African Americans are more prone to sickle cell. So for that, you're going to assess family history, whether anyone in their family has had it. And then if they're presenting with jaundice or hepatosplenomegaly, you're going to look further into that. African Americans, as well as Jewish Americans and Americans of Mediterranean descent, are also more prone to lactose intolerance. So you're going to see them having bloating, belching, discomfort after they consume milk products. People of Asian descent have a higher rate of liver cancer and also stomach cancer. So if they're presenting with symptoms of heartburn, indigestion, and loss of appetite, you could look further into that as a possible culprit for that. Americans of Jewish descent also have higher rates of ulcerative colitis and irritable bowel, so you're going to see exacerbations as far as constipation and diarrhea, upset, that may get worse with anxiety. And then again, the Americans of Mediterranean descent, you're going to look at possible chronic anemia or thalassemia. You're going to see pallor and splenomegaly there. And those two do not respond to iron supplements. When assessing patients across the lifespan, there's some things to be aware of as far as things that are common in each age group. When you're assessing a pregnant woman, keep in mind that some normal findings are constipation, a little stress incontinence, heartburn, and hemorrhoids are all things that you could see there. When assessing a newborn, you're going to ask the parents whether they're breastfeeding or bottle feeding and how they're tolerating that, how much they're eating a day, and how often. Sometimes parents get nervous that their newborn may not be eating enough, but you can reassure them that their infant is getting enough as long as they're meeting their growth milestones and they're saturating about 6 wet diapers a day and having at least 1 bowel movement per day. When you're looking at children, again, you're going to reassure them that their toddler's getting enough. Sometimes toddlers don't want to sit down and eat full meals, and the way they eat, they prefer to pick and have hand foods, and that's okay as long as they're meeting their growth milestones, so just reassure the parents there. You're going to make sure that they're not eating anything that they're not supposed to be, as far as dirt or clay, or paint from the walls in old homes. Sometimes pica, you see lead poisoning if they're eating paint from the walls. As far as for young children, if they're complaining of abdominal pain, there's a multitude of different things that it could be there. Sometimes you see abdominal pain when a young child has an ear infection, so it may seem unrelated, but that's one presentation that you could see. Since obesity is such a big problem in the United States, you're going to want to look and see if the child is obese and do some nutritional teaching there, as far as looking into seeing what foods are being offered to the child and what kind of body image they have there, and teach the parents some more healthy choices. For teens, what you're going to see is possibility for anorexia or bulimia, because body image is such a big issue there in that age group. A lot of times kids in the adolescent age group are skipping breakfast, and they really need that first meal in order to think and do well in school. They also need more calories than an adult would. A teenager, on average, a boy needs about 3,000 calories, and teenage girls need about 2,200. With older adults, it's not abnormal to see that their appetite is waning, and sometimes that could be due to just age-related changes. Sometimes they're not eating as well because of cognitive decline, less income if they're not working and they're living off social security, or they may not be able to make it to the grocery store often enough and just may be malnourished, so you're going to want to look at that. Also, with older adults, you have to consider polypharmacy, if they could be having any interactions between their medications that could be affecting their nutrition or their uptake or their appetite. Certain things like anticholinergics can cause dry mouth, and that may make them not want to eat or may have trouble swallowing, so that's something to look into as well. And then you're going to move on to the focused assessment. When performing the physical assessment, you're going to start with inspection, as always. Start by looking at the condition of the skin, looking for any scars or striae or visible veins. Make sure that the umbilicus is normal and there's no issues there. You're assessing size, shape, and symmetry of the abdomen, making sure it's the same from side to side. Note the presence of any edema or ascites in a patient with liver issues. You shouldn't be seeing any pulsations as far as abdominal aortic pulsations. except in the rare case you may see those in a slender patient that's laying flat on their back. Another abnormal finding would be an enlarged spleen or liver. And after you're done with the inspection part, you're going to move on to auscultation. And here you're basically listening for bowel sounds. Generally, you're going to start at the level of the ileocecal valve, which is here, and then you're going to go clockwise from there. Bowel sounds are generally high-pitched and gurgling. You're going to hear anywhere between 5 and 30 of those per minute. If you don't hear any, you might have to listen for up to 5 minutes before you say that bowel sounds are absent. Hyperactive bowel sounds could indicate diarrhea, or you could also hear hyperactive bowel sounds at the level above an existing obstruction. Hypoactive bowel sounds are going to be seen in ileus and peritonitis. If you hear a high-pitched tinkling sound, that could indicate trapped air or fluid. And then next you're going to auscultate for bruits and friction rubs in all 4 quadrants of the abdomen using the bell of the stethoscope, which I only have a diaphragm, but generally a bell is on the other side of the diaphragm. And you're going to listen in all 4 quadrants there, starting at the ileocecal valve and going around. You're going to listen at the level of the upper renal artery and the lower renal artery, and also the upper iliac and lower iliac arteries, the renal arteries on the right and the iliac arteries on the left. You're also going to listen to the abdominal aorta, which is about the region of the epigastric area. And if there is a presence of bruits, that indicates turbulent blood flow, and that could be due to an obstruction of the vessel. Then you're also going to listen over the liver, which is in the right upper quadrant, and the spleen, which is in the left upper quadrant, and you're looking for friction rubs there, which could indicate a tumor. Next, you're going to perform the percussion part of the exam, and percussion is basically used to detect any fluid, air, or masses, and also to determine the size of organs, to detect any organomegaly or tenderness. You're going to start by percussing all 4 quadrants of the abdomen, and you're basically going to take your non-dominant hand and place it on each quadrant, and then quickly percuss with your dominant hand. And you would leave the any painful areas for last, so that you could get through the exam. If you hear any dullness, that indicates the presence of an organ, mass, or fluid, such as seen in ascites. And you should be hearing tympanic sounds generally. To percuss the kidneys, you're going to use blunt percussion at the costovertebral angle, which is where the ribs meet the spine on the back. So you'll have the patient sit, and you will place the palm of your non-dominant hand at the costovertebral angle, and you're actually going to strike it with the fist of your dominant hand as such. The patient shouldn't feel any pain the first time that you percuss that area, and if they do have pain, then that could indicate pyelonephritis or possibly kidney stones. When percussing the liver, you're going to use the palm of your hand method. You're going to start at the right midclavicular line at about the 3rd intercostal space, and then start percussing downwards until you hear a dull sound indicating the presence of an organ. When you hear that dullness, you're going to mark it with a pen, and then starting at the midclavicular line at the level of the umbilicus, which is down a little more, you're going to actually percuss upward until you hear dullness indicating the presence of the organ. And then you're going to mark there, measure the distance between the two, and that will be the length of the liver. Normally it should be about 6 to 12 centimeters is normal. Then when percussing the spleen, there's a couple different ways, but the easiest way is basically to percuss from the left midclavicular line across the costal margin. You would percuss from the midclavicular line out to the along the costal margin up into the mid-axillary line, the left mid-axillary line. If the only sounds you hear are tympanic in nature, then splenomegaly is unlikely. To percuss the bladder, you're basically going to start at the level of the symphysis pubis and percuss upward. Percuss upwards towards the umbilicus. If you're hearing dull sounds, that indicates a full bladder, and if the patient is indicating pain or tenderness while you're doing that, that indicates the presence of a urinary tract infection. The last part of the physical exam will be palpation, and the reason we do this last is that sometimes if you palpate the abdomen first, it can kind of upset whatever is going on in the stomach, so it's best to look and listen first before you go poking around, as you might say. So you're going to begin with light palpation, and you're going to do that in all 4 quadrants of the abdomen, starting at the right lower. You're basically going to use your fingertips of your dominant hand, and you're going to go in a rotating motion, pressing down about 1 to 2 centimeters. And you're observing for any pain or masses. Pay special attention to any nonverbal or involuntary signs of pain. Patients that you shouldn't use palpation on is anyone who's had an organ transplant, as a lot of times when they go through that, the transplanted organ is placed more anteriorly than the original organ, and it has less protection then. And also, you should never palpate a child who you suspect of having a Wilms tumor, because that could cause seeding of the tumor into the abdomen. If the patient is exhibiting involuntary guarding of any area, it could indicate peritoneal inflammation. After that, you're going to do deep palpation, which is basically the same, except you're going to depress about 4 to 6 centimeters, and you're going to do that in each quadrant of the abdomen, and you're going to be using a rotating motion of your fingers. If the patient has an abnormally large abdomen, you may need to use 2 hands, and again, doing that in all 4 quadrants. So to palpate the liver, you are going to take the, since I'm right-handed, I'll be standing on the patient's right side for all of the palpation assessments for the liver, spleen, kidneys, and bladder. You're going to take the right hand and place it at the right midclavicular line under the costal margin, and then the left hand is going to go under the patient's back at the level of about the 11th or 12th rib. Then I'm going to press up with my right hand while the patient takes a breath, and I should be able to feel the bottom edge of the liver while they inhale. An enlarged liver will be palpable before they inhale, and it'll be palpable below the edge of the costal margin. A second method is the hook method, in which you hook both hands under the costal margin and feel the edge of the liver when the patient takes in a deep breath. Next, I'm going to palpate the spleen, and since I'm right-handed, I'm going to stay on the patient's right side. So I'm going to place my left hand under the left CNA and pull my left hand up to bring the spleen to the anterior part of the abdomen towards me. Then I'm going to place my right hand under their left costal margin and press in while the patient exhales. You should not be able to palpate the spleen. It's abnormal if you do. It would indicate splenomegaly, and you would see that in different disease processes like mono, HIV, any sort of metastatic cancer of the liver, or of the patients with sickle cell could have splenomegaly. Next, I'm going to palpate the left kidney. So I'm going to take my left hand and place it on the left CVA, and then place my right hand on the costal margin and capture the kidney between my 2 hands while the patient inhales. And I'll do the same on the right. While they inhale, you will then be able to palpate the kidney with your right hand when it's been captured between the two hands. The right kidney is normally not palpable unless it is enlarged, and the left kidney may only be palpable in slender patients. Enlargement of the kidneys could indicate hydronephrosis. Next, I'm going to palpate the abdominal aorta, and again, the patient's going to be laying for all these assessments. I'm going to take the fingertips of both of my hands and place them at the epigastric region, just slightly to the left of the midclavicular line. And both of my hands are going to be placed about 2 centimeters apart, and I'm feeling for abdominal aortic pulsations. If the aorta is greater than 3 centimeters, or if I'm feeling lateral pulsations, that could indicate a AAA, an abdominal aortic aneurysm. And then finally, I'm going to palpate the bladder, and for that you use deep palpation, and that's the hypogastric area near the pubic symphysis. So again, using deep palpation, going in about 4 to 6 centimeters, and if that's tender, it indicates that the patient either has a full bladder, there could be a mass, or possibly a urinary tract infection.